So Dr. Poornachandra is very passionate about electrophysiology, and he's a senior consultant in retina department in Narayan Nethralaya, and he'll be talking to us on fulfilled ERG, when to order and what to look for. If you have any questions, we can always take it at the end of the session as well, so please keep your questions ready.
So thank you, ma'am. So good afternoon, everyone, and thank you, Subhadra ma'am, for making my job easy. She has covered most of the basics of it. Okay, fine. So I'll be talking specifically about the fulfilled ERG, which is nothing but a mass response of a luminance stimulus, and which generates biochemical and ionic changes in the photoreceptors, which generates electrical potential, which is recorded as ERG. So I will go through some of the case scenarios where there is an uncertainty about what's happening, what's intended, and what is required. Let me start with the most commonest problem for which an ERG is indicated is night vision problem. So this was a story of 26-year-old male who presented with night vision issues. On examination, the fundus was absolutely normal. The autofluorescence and OCT was also normal. So 26-year-old without any structural abnormalities, complaining about night vision, you think of maybe malingering or some other problems. But we thought of doing an ERG on him. So we did a fulfilled ERG. If you can see here, as compared the blue ones which you are seeing is the normal one. The black line represents the patient's recordings. So here if you see, the dark adapted responses are almost undetectable. Okay. So that's the beauty of ERG, where you're structurally looking everything is normal, but the ERG is telling the rod system in the entire retina are non-functional. So then 26-year-old male presenting with a night vision problem in a normal looking fundus and an abnormal ERG, first thing we suspect is serum vitamin A deficiency. We ordered for vitamin A level. As expected, it was very low. But we are also physicians. We need to think of the reason why this vitamin A deficiency happened. Why should a 26-year-old have vitamin A deficiency? When I asked some leading questions, he told there is an history of dyspepsia, frequent loose stools and all. He underwent extensive workup to find out the cause for this malabsorption. Finally, an intestinal biopsy has to be done, where he was diagnosed to have intestinal lipofuscinosis, which is an end result of this chronic inflammatory bowel diseases. So because of which he had a malabsorption. So the ERG was repeated after supplementing the vitamin A. So we gave intramuscular injection. In case if that is not available, if you don't have any facility to take an opinion from gastroenterologist, all of you know, like we have the 25,000 international units tablets which are available in the OPD, that you can give it BD for 30 days. That also works equally well. And if you look at here, just 1 week after supplementing vitamin A, the behavior is almost coming to normal. By end of 2 months, his ERG is completely normal. So if not for ERG, not only a treatable retinal condition, but also a life-threatening condition would have missed in this case. Now coming to one more case scenario where an abnormal looking retina but the asymptomatic patient. This patient, 28-year-old male, vision 6/6, came for a routine checkup, and this is how a fundus looked. There are multiple flex-like lesion. OCT is again absolutely normal. All the layers are intact. So if you look at the fulfilled ERG is also normal. So this is a case of benign fleck retina. So most of the time these are stationary and unlikely to progress, though the retina may look abnormal. So they don't progress, and most of the time when they come for the clearance for a refractive surgery or premium hours, you can give the clearance. This is not a contraindication for any of the procedures. One more similar looking fundus, 36-year-old male, those flecks are there, not very obvious as the way you saw in the first case. This patient also had a vision of 6/6, but this patient told I have night vision problem, I have a delayed dark adaptation. We did the OCT again structurally it was absolutely normal. Now look at the ERG, the dark adapted responses are almost undetectable. If you look at the combined responses, there is something interesting happening here. The A wave is forming, the B wave instead of going like this, it's getting terminated here itself. It's not even reaching the baseline. So this is the classic electronegative ERG what we see here, and its light adapted responses are quite okay. So this is a case of fundus albipunctatus, which is a form of congenital stationary night blindness. Okay, there are many other things. Basically, there is some problem with the bipolar cell transmission, and B wave is from the bipolar cells. That's the reason we get electronegative A wave. So this is again to summarize, the both almost similar looking fundus, but the ERG once you do, both are completely a different entity. And second one, as I told, it's a stationary disorder and it's not going to progress, unlike an RP, not to get confused with RP related night blindness. Fine. Then normal looking retina with an unexplained visual symptoms. This was a 26-year-old female, recently married, brought by husband because she was quite inattentive to the surrounding, and there was no positive family history. Vision, she was giving variable responses whenever we checked the vision. We still today we don't know what's her vision. Anterior segment, posterior segment, everything was normal. And this is our OCT. I'm showing you all the cross sections. Absolutely normal OCT. Autofluorescence also near normal. So what do you suspect? Recently married, brought by husband, everything is normal. The first thing you suspect is maybe malingering. Okay. So, but you should not label any patient as malingering without subjecting them for an electrophysiological test. That's what we did in this patient. If you look here, the light adapted responses are undetectable. So whereas the dark adapted responses are, my cursor, yes, it's absolutely normal. If you look at the light adapted responses, it's an undetected, it's a flat line. So what OCT is telling is everything looks normal, but the ERG is telling the cone system in the entire retina are non-functional. So this is a case of achromatopsia, which is a form of stationary cone dystrophy. So this is the kind of OCT changes what we usually see, which resembles a photic retinopathy, but our patient did not have that also, which is quite common in this cone dystrophy kind of disorder. One good thing about this is again a stationary disorder. It's unlikely to progress and it's not a blinding condition. All they need is photochromatic glasses, some little bit of counseling and low vision aids. Then one more category, very common, having taken multiple opinion, what's wrong with my eyes? This is one such story. This was a 25-year-old male, had a night vision problem, no positive family history. Best corrected visual acuity was 6/9, color vision was normal, anterior segment was also absolutely normal. So when he draw the pedigree, he was born out of a consanguineous marriage. He had one more brother who did not have any issues. So this was his fundus photo. When I saw that, I was very happy. This is a very classic Mizu-like reflex. So I thought maybe I'm dealing with one of those CSNBs or Oguchi's disease. Then I ordered for an ERG OCT testing just to make document. So this is the wide field autofluorescence. There was some autofluorescent ring in the periphery with small flex-like deposit nasal to the disc, more prominent in the left eye. So this is the same autofluorescence of the posterior pole. When I did an OCT, there are some interesting changes in the perifoveal region. There are some skytic changes which should not be there if it was a congenital stationary night blindness group of disorders. It should be normal. Okay, so then I thought of night vision problem, skytic change. Maybe it's a juvenile retinoschisis. Then I thought, okay, I'll do an ERG. I'll get electronegative ERG. I'll report and give it to you. Then when I ordered an ERG, I was in for a surprise. There was no electronegative ERG. So there's a gross reduction in dark adapted responses, and dark adapted combined responses are also delayed and decreased in amplitude, and same thing was seen in light adapted responses. There's one interesting thing to observe is the dark adapted 3.0 ERG and light adapted 3.0 ERG look very similar. And I'll tell you, this is very specific to one condition. I'll explain that. So then these are the scenarios where we need to do some of the extended protocols which Subhadra ma'am just told. So that's what we did here. We stimulated the long and medium wavelength cones. We gave them the blue background to silence the short wavelength cones, and we stimulate the retina with the orange light, long wavelength. For that, what we got is an undetectable response. When we did the opposite, like we use the orange background, stimulate with the blue light, what we got as a enhanced response. So this is a classic case of enhanced S-cone syndrome. So there are few conditions like ACNV mutations and enhanced S-cone syndrome where ERG is the diagnostic. You need not even go for the genetic testing. So to conclude, I would like to say electrophysiology is an important tool to aid the diagnosis in various diseases. It should always be followed by clinical correlation and another imaging modality. Don't take this in isolation. And additional genetic information in case of dystrophies might help. Thank you so much.
Excellent talk, Poornachandra.